just want to check I have the right version. Yes, I do. Okay. Okay, can you still hear me?
Yes, you're good to go.
Thank you. So myself, I'm placed at Lesion Extension 13 Clinic, and my colleague is at Iterling. So together we've taken some of the dermatological conditions that we saw most commonly at those sites and put it together into a presentation. And we've also included ones that we didn't see, but we thought were important. So we're just going to go over these few things in order. We'll start with basic anatomy and physiology. So I haven't put the details on the screen, but to start with embryological development in the human skin, we have ectoderm and mesoderm. Ectoderm gives rise to the epidermis and other skin appendages, and the mesoderm gives rise to the dermis and subcutaneous fat. These together make a layer of mature skin, which you can see on the image.
Nabila, sorry to interrupt you. I think we're just struggling to hear you a bit. I'm not sure if... yeah, that's a bit better.
Is that better?
Yeah. Sorry about that.
Okay. Sorry. Should I start again?
Just from the slide, if you can.
Okay. So we'll start with the anatomy of the skin, embryologically.
Nabila, sorry, I think we are losing you again. I don't know what the others say. We can't hear you too well.
And now?
Yes, that sounds good. No, we can't hear you so well now.
I don't know what's going on. And over here?
Yes, that sounds perfect. Don't change anything.
Okay.
All right.
So the layer of the skin, with the epidermis and skin appendages, and the mesoderm to dermis and subcutaneous fat. Together, those make the mature layers of the human skin, as seen in the diagram. And there's subdivisions within those layers. The basal, layers. Each of those containing different cells. So in the basal layer, we have polygonal cells, and the stratum granulosum, we have flat long cells, and the corneum, we have mature keratin cells, and the molluscum, which you find on the palms, and we only find on the palms and soles, so that's then, with regards to the epidermal appendages, we have the parasebaceous follicles, as well as the eccrine sphere. We'll then go on to functions of the skin. So there's a whole list, but I won't be talking too much about them so we can get more into the conditions. Some of the functions include sensation, like detecting temperature, as well as if objects are sharp or if they're dangerous. Protection from UV light, as well as infection. Temperature control, sweating and insulation. Chemical lubrication by controlling our skin pH. Immunological, as some of the layers contain immunological cells that are our defense to first defense infection, and then hormonal, with regards to the conversion of vitamin D from exposure to the sun. Then with regards to principles of diagnosis, it's kind of generalized to most things in medicine. We start with a history and examination, sun history, the duration, site spread, if it's an index presentation, if it's recurrent, if they've had previous treatment, if they've been referred before, if there's anyone at home or at work that has the same thing, if there's things at work that they're exposed to, and also importantly, how this affects the social status with regards to how they view themselves, and as well as psychological effects. On examination, it's as usual, inspect, palpate. So we're looking at where the skin is exposed, demographics, where the person works, where the person lives. Also site, where on the body it's happening, what kind of pattern it's happening, and most importantly, the primary lesion, which is important in derm to describe, which will help us make our diagnosis. So then on to definitions. We usually use primary lesions to determine the diagnosis of the dermatological condition. So I've listed a few here, and then I've included some pictures in the next slide, which I'll use to explain. Primary lesions are the first lesions we see occurring in a certain condition, and then the secondary lesions usually come after the primary lesion, and it's usually subacute or chronic when the condition has not gone away. So in the pictures, if my point is working, so the one I'm pointing to are macules, which so macules are flat, well-circumscribed, discolored areas on the skin. They're usually small, and then the larger version of that would be a patch. So that would be this picture here. So a patch is basically a larger macule. We then have papules. So a papule is a small, round, raised, solid lump. And then the next one after that would be a pustule. So that is also a raised lump, but contains pus, and then that would be that for me. A wheal seen with allergic reaction. So that's a pale or a discolored area of skin with surrounding edema, usually erythematous. Then this one is a nodule. Nodules are also round, raised, solid lumps, but they're usually larger and deeper than papules. Here we have vesicles, which are fluid-filled cysts. And then here is when vesicles burst. So when vesicles burst, it's called weeping, and then they eventually crust and become dry. And then this would be a plaque, like we see in psoriasis. So that is a large induration, usually quite scaly and raised. And then the one that I haven't included here would be a papilloma, which is a warty outgrowth, and we do have some pictures of warts later. And then large bulla, which are just large versions of vesicles. So just leave this. With regards to principles of treatment, with derm, we have topical, which is directly onto the skin. So we have lotions, ointments, creams, pastes, topical antibiotics, as well as certain dressings. And then we have systemic treatment for more severe or non-responsive cases to topical treatment. Those include antibiotics and corticosteroids and a few other agents we'll mention. We'll start on the common disorders. So eczema, I'm sure everyone struggles with eczema, and I think we're all kind of guilty of diagnosing eczema when it's not actually eczema. So we'll start with the definition of it being an immunologically mediated inflammatory skin disorder. Can either be caused by external factors or internal factors, and these factors can either occur alone or can all add together to cause eczema. Symptoms that a patient will usually come with would be a rash that's itchy, red, dry skin, seasonal, usually at the beginning of summer or the beginning of winter. Signs on examination that we're looking for. So we have acute, subacute, and chronic. The primary lesion we're looking for in acute would be erythema surrounding edema, superficial vesicles that can become crusted and weep. And then after that, we get the scaling, and they could also get secondary infection if, especially in kids, they keep scratching it, which we can't really control in kids because they don't know what's going on, so they'll scratch it anyway. Subacute, we have papules and scaling, and then chronic, we have lichenification sometimes and changes in pigmentation, which I'll show you in the pictures to come. Eczema is classified into two different types: constitutional, which is endogenous, which can also be hereditary. So we get that with the atopic kids, and which can continue into adulthood. They usually have the hay fever, the urticaria, the asthma, and the raised IgE. Again, commonly in infants and children. And the clinical types would be, so what we see on these kids, infantile, so that would be in the younger babies, and I'll show you pictures of where we expect to find these lesions. Flexural and flexural surfaces, follicular, sorry, sorry, I'll move on because I can't find my note on that one. Nummular would be round, coin shapes on the limbs and the trunk, and then hand and foot eczema around the fingers and the toes. Then, besides atopic, we have seborrheic skin regions with large sebum productions and large body folds. I'll also show you some pictures of where patients have it around the neck. So again, we have it in infantile, which is in kids, around the scalp, where especially the hairline, where there's lots of sebum. Blepharitis is within the eyelashes, eyebrows. Intriginous would be groin areas. Otitis externa in the ears, like discussed previously in the previous presentation, and then sun-sensitive areas as well. And then we can have, if it's not constitutional or endogenous, other factors that cause it. So local causes in the skin, dryness, infection, contact with certain chemicals or surfaces, venous hypertension, trauma, UV light and sweating. And then systemic causes could also be infection and drugs. With regards to the management of eczema, it's quite difficult because we don't have a lot of at our disposal, especially in primary healthcare. So we need to educate, especially with regards to kids, we need to educate the moms to moisturize the skin, to keep the kids away from any triggers that might be causing the eczema, to bathe them with emulsifying agents to moisturize the skin. And then also when using moisturizers, I know we like to prescribe Milocort. So for kids especially, not on the face, and if they are going to use it on the body, they need to dilute it within aqueous cream so that it doesn't cause any long-term side effects. And then also we need to treat infections. As previously mentioned, when the kids scratch, then they usually have bacteria under the nails that causes infection, so we need to make sure to treat that as well. When to refer when nothing is working, as I'm sure a lot of us have seen in the clinics, we just have bad cases of eczema that need to be referred to a specialist dermatologist. So in the pictures, I'm sure we've all seen a lot of babies with eczema on the cheeks. And then you can see here in young children or the infantile type, they get it on the knees, the elbows, the head, and the cheeks. Then here is here with the skin folds by the neck. This is an example of lichenification, the chronic eczema changes. Here's flexural type eczema. This is also in a baby. And here on the extensive surfaces, again, scratching causes a lot of erythema, subacute, and chronic changes. Okay, then we're going to move on to psoriasis. It's a T lymphocyte inflammatory mediated disease. Also has two causes, genetic and environmental. So symptoms, the patients usually come, they say it's not going away, treatment's not working, it's itchy, it's red, it's becoming worse, it's spreading, it's hard and it's scaly. What we're looking for in examination, the primary lesion is a plaque, which is thick and silvery white. It looks scaly, it's well circumscribed, raised, and can be red at times. Then there's also two signs that you can use on examination. The first one is the Oshpit sign, which is pinpoint bleeding under the scale that is removed. So if you remove part of the plaque, underneath there'll be pinpoint bleeding. And the Kubner phenomenon would be new skin lesions over normal previous skin secondary to trauma, and psoriasis tends to form there. Then classification, this is basically just where it occurs on the body, so or the type. So plaque would be the normal one that we see. Catate is a different kind of presentation, so it's small droplet shapes on the legs, the arms, and the trunk. Flexural in the flexural regions, arthritic involving the joints. Pustular, which is just involve pustules of the plaques, and then nails with the nail pitting. With regards to management, again, topical versus systemic. A lot of the stuff we don't have in primary healthcare facilities, so it often requires referral, but we can use short-term topical corticosteroids, again, usually best when diluted to avoid long-term side effects, and there's also the vitamin A and vitamin D derivatives. Systemic obviously would be more specialized, require a dermatologist to prescribe. Methotrexate is systemic retinoids and cyclosporin. It's quite a difficult condition to treat, and then you can see the sorry, the plaques on the knees, and then the one on the left would be the guttate one that's on the, the guttate one that's on the limbs and the trunk that has little pustules on it. And then here's one of the scalp. Okay, then moving on to acne vulgaris. So it's chronic inflammatory disorder of the pilosebaceous follicle. If you'll remember in the anatomy, I mentioned that the pilosebaceous follicle is one of the skin appendages of the epidermis. So there's many causes to it. Could be hormonal, genetic, climate, diet, psychological, or certain medications or drugs, each of which require their own management or different. So you can have all of these or one of these and introduce the management for each one as a whole. Symptoms, so the patient will usually come with large pimples on the face, saying that they don't feel like going out because they feel like they don't look nice anymore, and it can have a really bad psychosocial impact. Pimples can also be painful. It can also have secondary infection signs. So the primary lesion is usually a comedone. Open comedones have been exposed to oxygen and therefore called blackheads. Closed comedones are whiteheads if they haven't been exposed to oxygen yet. Then there's also, papules, pustules, nodules, system scars, which you'll see in the next slide when I show you the pictures. And often that's how it progresses. The classification, so again, the type and where it occurs on the body. So vulgaris is the common type. Conglobate is quite a severe type. It's the most severe and involves deep abscesses and cysts. Fulminans is ulcerating and hemorrhagic. So conglobate and fulminans are the two most severe and probably the least that we see in primary healthcare. And then you can also get cosmetic and occupational secondary to like wearing makeup or occupational contacts with certain chemicals. With regards to management, again, topical and systemic. So topical common diuretic agents such as benzoate gel, encouraging the patient to not use oily products, to use oil-free products, also to use products with salicylic acid, lactic acid, etc., which I'll show you on the next slide as well. And then systemic-wise to decrease sebum production. So we have systemic retinoids such as Orotane and Roaccutane, and hormonal, which is a combined oral contraceptive. So again, that usually requires referral to a dermatologist because Orotane and Roaccutane come with their own side effects. And then with regards to superimposed infections and inflammation, we also have topical antiseptics and antibiotics. And if infections are bad enough, we need to use antibiotics and steroids if very severe, but caution with the steroids and long-term use due to their side effects. So in the pictures, you can see this is the typical presentation. So they'll have a lot of pustules, papules, erythema, sometimes edema, crusting after the pustules have burst. Over here you can see they describe the lesions, whitehead, blackhead, which is the comedones, papule, pustule. You can also have nodules at times. These are just some of the treatments or the agents that you can check for in topical agents that fight against the sebum production and exfoliate the skin. And then you can see the process of the acne. So here in the epidermis and the pilosebaceous gland. So it becomes blocked. None of the sebum or shed keratin gets to come out. And so it first produces a papule and then later a pustule, and eventually this becomes inflamed and very large. And this is an example of the scarring post the process of post comedones, post papule, post pustule, post weeping, and then we get chronic scarring. Then this is just how we grade acne, and like it helps us to refer for treatment. So mild acne, they mostly have non-inflamed blackheads and whiteheads, so the non-inflamed comedones, maybe a few papules. Then for moderate, so for that we use mostly topical. We don't have to go to systemic treatment yet. With moderate acne, we have a higher number of comedones and more pustular-like lesions and a lot of red inflammation, which could warrant stronger topicals or possible introduction of systemic. And then severe deep cystic, that was the conglobata and the fulminans ones. So there's a lot of pustules, there's a lot of inflammation, a lot of crusting and a lot of weeping of the pustules that can cause those scars. So that for that, we definitely refer to tertiary, and they would need systemic treatment.
So I'll be going over the infection-related skin conditions. So the first one I'll start with is Impetigo. So causes is mostly Staph aureus and beta hemolytic strep, but it could also be both. So it's most commonly found in children, is highly contagious, and it may follow minor trauma, scabies, eczema, or occur de novo. So the primary lesion is superficial. It's usually a thin-walled vesicle that ruptures to exude a serous or a purulent fluid, which then dries up to form crusts. So they could actually, the lesions could actually enlarge and spread rapidly. So it heals without scarring, so there's no complications. In terms of treatment, you can use a topical antiseptic or an antibiotic ointment, as well as oral antibiotics, for example, if it's associated with a strep throat or any other associated symptoms like a sore throat or anything. Then Molluscum contagiosum is a self-limited epidermal viral infection, and it is caused by the pox virus. Also, highly contagious, occurs in children, sexually active adults, as well as immunocompromised adults or HIV. The lesion is a dome-shaped papule with a central umbilication through which a thick white substance can be expressed. So treatment is to reassure the patient. So how to treat it is to irritate and basically create an immune response locally at the lesion. So topical irritants could be lactic and salicylic acid, silver nitrate sticks, cryotherapy, curettage. But because of our limited access to treatments, we can, home remedy would be lemon peel soaked in vinegar. Most importantly, if it's HIV related, to actually counsel patients in terms of adhering to management, so heart, Then tinea. So tinea is a dermatophyte, also commonly known as a ringworm, So it infects keratinized epithelium, hair follicles, and nails, and it is named according to its anatomical site. So capitis would be the head, corporus would be the body, manum would be the hands, pedis would be the feet, and crurus, so the groin areas. Then lesion, it's a round patch. So if it's on the head, it will be associated with a hair loss, with scaling, and then it would have a round, active, raised, scaly edge. So treatment is to consider any underlying conditions, so diabetes, HIV, to avoid dampness, so to counsel on drying feet correctly once getting out of the shower or bath, hygiene, so hair brushing, not to share hair brushes, and then topical ointment, so you could use clotrimazole, which we do have access to, terbinafine cream, commonly used with athlete's foot, and then oral medication, griseofulvin, itraconazole, and then also terbinafine. And that covers tinea. Measles. Measles is caused by the rubeola virus, also highly contagious. So usually presents with the 3 C's, cough, conjunctivitis, coryza, with associated fever, as well as complex spots. So usually whitish bluish spots seen in the mouth. Most importantly, that we are covered, or our EPI does include immunization against measles. So it is a notifiable disease. It is usually self-limiting. You can treat symptomatically. So the fever, the cough, the runny nose, and then importantly to isolate once confirmed with measles. And then chickenpox is caused by the varicella zoster virus, also highly contagious, presents with constitutional symptoms, so just general feeling of not being well, so fever, loss of appetite. Yeah. And then, so it starts off as successive crops of pruritic vesicles, pustules, crusts, and then scars. The treatment is also self-limiting. You can symptomatically treat and then also isolate. Herpes zoster is the reactivation of the varicella zoster virus, which causes an acute dermatomal infection. So usually it starts in a dermatomal area. So usually in one dermatome, it is a unilateral pain, versicolor or bullous eruption. Treatment is just in terms of it's commonly seen in immunocompromised patients, as well as we've also seen it in patients who are not immunocompromised. So it could also just be in terms of anyone who is under stress or yeah. Treatment: systemic steroids for neuritis, oral acyclovir. If it is severe and disseminated, it would require IV acyclovir. You need to treat secondary infections. And if it involves the eye, then it is for ophthalm referral. Importantly, also to educate and reassure the patients, and also regarding the neuritis, to inform them that even when the lesions have healed, the neuritis continues for a few weeks, up to months. Herpes simplex, so there's HSV1, which is commonly associated with genitals, lips, mouth, cornea. HSV2, mostly associated with genital ulcers and perianal. Primary infections, so these are seen in kiddies, so gingival stomatitis. And then your secondary infection would be fever, blisters, cold sores, which are basically just clusters of vesicles on a red base. They dry up within 2 weeks. Recurrent HSV may be precipitated by fever, sun exposure, and then mainly in immunosuppressed patients. Your treatment could be IV acyclovir or oral for severe infections. If it's for cold sores, you can use a normal over-the-counter, topical ointment. Then scabies is infestation of the skin by the human itch mite, known as Sarcoptes scabii, also highly contagious. So the mite burrows into the upper layer of the skin where it lives and lays its eggs. Symptoms is intense itching and pimple-like skin rash, which is papular, could also form vesicles, tiny blisters, and scales. The common sites is the wrists, so webbing between the fingers and the toes, the waist, belt line, elbow, buttocks, and it's spread by prolonged direct skin-to-skin contact. So importantly is to cut fingernails, especially if it's really itchy, to avoid any secondary infection, washing of bedding, underclothes, and actually all clothes in hot water. Expose all bedding to direct sunlight. Then benzyl benzoate 25% lotion can be used as well. So it can be applied for 24 hours, then washed off. The patient needs to be counseled that all contacts at home or whoever they've been in contact with should be treated as well. If benzyl benzoate does not work, permethrin lotion can be used, and just depends on our access we have in the primary healthcare setting. warts. So warts, we have common warts. So sorry. So so common warts, these are just warts found on the hands and actually just anywhere on the body. It's nodular, it's a nodular type lesion. It's common in children, and then they actually can undergo spontaneous regression sooner or later. So plain warts, these are multiple flat warts. It could be on the face or the limbs, also in children as well as adults. Careful inspection could actually reveal a warty surface, so finger-like projection that you notice. Then plantar warts, these are usually seen on the soles of the feet, so it's hyperkeratosis. It's due to pressure. They are flush with the surface of the skin. And then venereal, these are warts seen on the genitals. They were all caused by strains of HPV. Lesions, they are papillomatous warty surface, so your finger-like projections. Treatment, so also topical irritant to create a local immune response. A home remedy would be lemon peel that has been soaked in vinegar and applied to the warts. Important to note is that warts shouldn't be cut or sutured, as that would cause scarring. Salicylic acid can be used, silver nitrate sticks, as well as cryotherapy. Obviously, these cryotherapy could be done at dermatology. Okay, then just the top left picture. This is an example of scabies, so it's commonly on the hands. Then this is an example of just common warts. So they're very nodular, they're almost white grayish. Yeah. Then this would be an example of what chickenpox would look like, vesicular, nearly, with crusting as well. Then this is a common, there we go. Bottom left would be what measles would look like. So it usually starts in the neck and then spreads towards the torso. And then that is many like red, inflamed papules. Then this is what HSV1, your cold sores would look like. There is some crusting there as well. This is tinea capitis, so well circumscribed with some hair loss. It looks quite dry as well. Then this would be impetigo, usually around the mouth and nose with some crusting. These are actually, the pictures on the right are actually pictures that with consent have been taken at one of the clinics that we work at. So top right, this is a typical lesion of Molluscum contagiosum. So it's an umbilicated lesion with what looks like a white substance that's inside that could be expressed. Then this is a picture of, bottom right is a picture of varicella zoster. So herpes actually, herpes zoster, found in the RVD reactive patient, immunocompromised. Still vesicles form, there's no secondary infection. It's been in a dermatomal pattern. And just to touch on a few pigmentation-related skin conditions. So just an example of both. So there's hyper and hypopigmentation. So the first one, hypopigmentation. So other examples would be pityriasis alba, vitiligo, albinism. Vitiligo is acquired localized loss of melanocytes due to autoimmune destruction and can also be associated with other autoimmune conditions such as diabetes mellitus. Clinically, it's well circumscribed, usually symmetrical like patches. They start off small but then coalesce to form irregular, sharply demarcated borders. Treatment is unsatisfactory. Patients do present with psychosocial, like it affects the psychosocial components of life. Treatment is unsatisfactory. Potent topical corticosteroid creams can be used, but not for longer than 3 months. And then in terms of, just for completion's sake, what dermatologists use is something called PUVA. So it's a tablet, so Sorlin, or topical combined with UVA rays. And then just in terms of sun protection, sunscreen, and then cosmetic covers could be used as in a short term. Yeah, in terms of just like helping psychosocial obstacles. Hyperpigmentation, so there's post-inflammatory chloasma, cosmetic actinosis. We'll be covering melasma, which is chloasma as well. So it's basically increased melanin in the basal layer epidermis with well-circumscribed macules, symmetrical, mainly on the forehead, cheeks, nose, upper lip, and chin, usually due to increased estrogen, progesterone in pregnancies and combined oral contraceptives, and is worsened by sun exposure. Treatment is to avoid the sun and then also the use of sunscreen. So in the top left, there's an example of melasma, so this hyperpigmented lesion seen on the face, and then bottom right, vitiligo and sort of a symmetrical spread. Then just skin cancers, briefly cover 3 of them. So squamous cell carcinoma is an uncontrolled growth of abnormal squamous cells. Risk factors, unprotected UV exposure, so whether it's the sun or tanning beds, fair skin, weakened immune systems, over 50, common in male, more common in male, precancerous lesion of actinic keratosis. So actinic keratosis is basically just a scaly, darkened piece of like patch of skin that has been recurrently exposed to sun. Treatment is importantly to refer, and then you can use topical treatments, radiation, and surgery. Between squamous cell and basal cell, squamous cell is likely to metastasize, but a basal cell is the most common skin cancer. So basal cell carcinoma is uncontrolled growth of abnormal basal cells. Risk factors are as for those for squamous cell, and then treatment also just to refer, and then topical radiation and surgery. So melanoma is uncontrolled growth of abnormal melanocytes. Risk factors, pale skin, light hair, eyes, and the atypical or mini moles, sun exposure, older age, and then treatment, radiation, chemo, and surgery. Then importantly is the ABCDE examination of moles. So on the next slide, so just in terms of, especially for your melanoma, A is for symmetry. So on the left, you'll see the normal, and the right, the cancerous. So if you draw a line through the middle of the mole, the halves of a melanoma won't match in size. So as you can see there, B is for border. So the edges of an early melanoma tend to be uneven, crusty, or notched. So it's very uneven, whereas normal is quite well circumscribed. C is for color. So healthy moles are uniform in color, and then melanomas usually have a variety of colors. So it could be from light brown, dark brown, blue, which means that they could be cancerous. D is for diameter. So melanomas are usually large in diameter. And then although they can be smaller, and also they actually can grow as well in size. And then E is for evolving. So yeah, when a mole changes in size, shape, or color, or begins to bleed or scab, this points to danger. Then just in terms of being able to differentiate between squamous cell and basal cell, there we go. So basal cell is more of a flat lesion, sort of erythematous with some crusting. So it's, yeah, it's quite flat. Whereas your squamous cell is more of a nodular type, also with different colors present. And then that would be an example of a melanoma with different colors present and then not being asymmetrical. And then, yeah, just the different kinds of skin cancer. So this is an example of actinic keratosis, which is just a patch or a macule of hyperpigmented skin, which has been exposed to sun recurrently. And that's that. This is our references we've used. Yeah, thank you so much for listening.
Thanks, Nabila, for that presentation. Dermatology is always a lot. The skin is the largest organ of the body, and yet we don't really pay sort of adequate attention to it. I don't know if there are any questions or comments.
Shane, can I make a comment?
Please, Dr. Petkova.
Again, I want to give practical tips. What is the most common trigger for eczema in children which are maybe with the family history of asthma or eczema? What is the most common trigger? I'm asking the audience. So they need to advise the parents what to do. Does anyone have a...
So sorry.
Yes?
Hi, can I speak? With regards to asthmatic kids, I guess that carpets and a lot of dust and pet hair at home could be triggers to atopic kids. So they have to counsel them on if they have carpets, to clean the carpets often or to at least get rid of the carpets. And then also, I know it's difficult for kids, but to limit keeping pets.
What else?
I'm not sure.
Okay. The colorants of the cold drinks. The most common cold drink that people send with children to school is the juice Oros. That one that we dilute with water. It contains colorants, and that is one of the biggest triggers for eczema. So any other cold drink that is containing colorants and preservatives also, they are a big trigger for eczema. Okay, so bear in your minds that to advise the parents, don't send with kids that Oros or any cold drink. Don't give them money for cold drink. Advise them to buy something else if they can. Yeah. So the other thing I want to ask is what other skin conditions are contagious? Are all the skin conditions contagious or they're not contagious?
So another ones that we mentioned were like Molluscum, Contagiosum, chicken pox, and measles. I don't think any of the others that we mentioned are contagious. Oh,
okay.
Scabies.
Yes, yeah, those ones, yes. But bear in your mind that bullous pemphigus, it's a contagious disease.
Oh, okay.
Not a common condition, but it's not excluded from the skin conditions. So bullous pemphigus, if you see a patient with the bullous on the body, and it's pemphigus, diagnosed histologically pemphigus, it's contagious. So keep in your mind that skin conditions which are contagious. So to protect yourselves. The other thing what I wanted to say, it's a practical tip. Impetigo, you can treat with Bactrim, the topical antibiotic Bactrim. It works very well. Unfortunately, it's not available in the government. It used to be, but it was removed from the EDL. So now only outside of, in outside pharmacies can be obtained by the patients. Okay, so that's from me. Thank you.
Thanks, Dr. Petkova. Do we have any other questions or comments? Alrighty. I think, Nabila, very good presentation and many difficult topics to consider. I think the key with dermatology is that you always, often when we look at a patient, we like to jump to a diagnosis. So, which is one thing that the final year dermatology registrars would fail their exams if they did that, because the sort of underpinnings of dermatology is completely described in the lesion. So saying, is it symmetric? What is its distribution? What the lesions look like? Is there positive Asbo-Hansen or Nikolsky sign? And sort of, they really follow a ground up approach. So when you're faced with something that you don't know at the clinic, try to describe it as much as possible. And then when discussing with the senior or with dermatology, that would allow them to give you more accurate sort of feedback around what the potential cause could be. And yeah, sorry.
No, I just wanted to say thank you for the advice.
Sure. And I think with regards to acne, so the retinoids, we don't start in the primary healthcare, and that's because of the risk for liver or renal injury that they do monitor. But what we can do, particularly for comedonal acne, is the sort of topical agents, as you've said, and then oral doxycycline, of course, for a month, and then review their symptom improvement. And so classically, they do get better with that, and then you can sort of tailor that duration of treatment to their response. Another technique that the dermatologists use is write up a private script for Retin A, which is topical isotretinoin, and that you can't be used once off, but regular usage sort of restores the sebum production of the glands and helps to reduce. And then failure of that, we could look to refer to dermatology. And then there was something else. Oh, with regards to unknown skin lesions, oftentimes we panic and we think, okay, is this squamous cell or basal cell, or is it just actinic keratosis? And what dermatology like to do is they clearly describe the lesion, note where it is, and something that we can do at the clinic is the punch biopsy, so the skin punch biopsy. And so, yeah, you go through the margin and the active site. So try to include an active site and margin of a specific lesion, and then document clearly for the histologist what it is. And take off several different sites if there are different concerning lesions. And you can use that then to refer to the dermatologists. And so the key thing is that we want to move away from a system where we don't know what we're doing and sort of just pass it on to another person, but rather optimize what we can achieve on our side so as to facilitate early diagnosis and less loading of care onto the central systems.
Okay. Thank you so much, Dr. Murphy.
Of course.
Thank you.
Shane?
Yes, Dr. Petkova.
I want to give another practical advice for tinea capitis. Most often place that children get it is from the barber on the street. So advise the parents that this was done this condition has developed because they took the child to the barber on the street, and the tools which the barbers are using were not disinfected properly, not treated properly, and they got it there. So advise them to not to take the children ever again to the barber on the street, or to buy their own hair cutting machine, which they can use it only at home, and maybe on the children only. So that is another practical advice. Thank you.
I definitely agree with that, Dr. Petkova. And for the interns, I'm sure you've seen adult males who have a sort of nuchal comedonal fungal infection at the nape of the neck. And that's also from barbers that are not sterilizing their equipment properly. And all of the tinea infections that you did speak to, Nabila, they are treated with topical, except tinea capitis does need oral antifungals for at least a month. Yeah, for that penetration.
Oh, okay. Apologies.
No stress. Any other questions or comments? Alrighty, then I think, Dr. Petkova, I don't know if we can conclude.
Yes, we can conclude. Shane, thanks for leading the session this afternoon. It was very helpful. I hope that the interns have learned a lot from you. And they had wonderful presentations. And I wish to encourage them next week to prepare a case presentation so we can discuss, because we've got enough time. We did catch up already our afternoon that we missed, and now we can do the presentation, a case presentation, and do the discussion as well. So I would encourage the interns to prepare for next week and send it in advance so people can have a look and maybe have the idea what we're gonna talk about. All right, thanks everyone.
Definitely.
And have a good afternoon.
Thanks everyone, have a good afternoon. Cheers.
Thank you, Dr. Murphy and Dr. Petkova.